Welcome to an IAPMD Professionals webinar. In this presentation, Dr. Lauren Osborne will discuss current efforts to train clinicians in reproductive psychiatry.
So I'm Lisa Hatzel. I'm a clinical psychologist and an assistant professor at the Johns Hopkins School of Medicine in the Center for Women's Reproductive Mental Health. And I'm really excited today to get to introduce Dr. Lauren Osborne. She's a good colleague and friend of mine, and she's going to be talking about her really exciting work with the National Curriculum in Reproductive Psychiatry. And I'll go ahead and sort of introduce her, and then there are a few background slides, and then we can get started. So Dr. Osborne is the Vice Chair of Clinical Research in the Department of OBGYN at Cornell School of Medicine. Her research focuses on biological mechanisms of perinatal mental illness, and she runs, and I love this name, the PIPI Lab, Psychoneuroimmunology in Pregnancy and Postpartum at Cornell. She's also chair of the Education Committee for Marcy of North America, and she's founder and chair of the National Curriculum in Reproductive Psychiatry, or NCRP, which is a free web-based curriculum for reproductive psychiatry. And that's the work that she's going to be talking about today. So we're super excited to have her.
So what we're going to talk about today is efforts that my group and others are making to train clinicians in reproductive psychiatry. I think one of the things that people who suffer from premenstrual mood disorders know is that it's very hard to find a clinician who's actually trained in this area. And I'm going to talk about this project, a national project that we have to improve the training we have in reproductive psychiatry. We started out with psychiatry trainees, but we're now branching into other areas, and I will explain that as we go along. So I don't have any financial conflicts of interest, but I want to just note my funding here, including funding specifically for the NCRP, which is from the American Board of Psychiatry and Neurology. So what is reproductive psychiatry? I think a lot of people use different terms to talk about this field that we're in. And the term that I use and that I'm going to be using exclusively today, I just want to define it as reproductive psychiatry. I consider it that branch of medicine that encompasses the science and practice of treating mental, emotional, or behavioral disturbances that are related to female reproductive transitions. So it's not the same as women's mental health, right? Women's mental health is a broader field, a multidisciplinary field that's really focused on the influence on psychopathology and treatment of a broader set of things. Female gender, things like gender roles and gender-linked trauma, female sex, having to do with things like brain sexual dimorphism, comorbidities that are specific in females, pharmacokinetic sex differences, and then also female reproductive cycles. So reproductive psychiatry really is a subset of women's mental health. And how have we gotten to this point where we have such a thing as reproductive psychiatry as a subset of women's mental health? Well, I think one way to start to understand it is to think about how things have evolved in women's health generally over the last 30 or 40 years. So we really started the current push toward improving the lot of women's health back in the 1980s, when the first Public Health Service Task Force documented the fact that women are being excluded as participants from many major NIH-funded studies, and really called for an expansion of that research. In the 1990s, we had the establishment of the Office of Research on Women's Health, and Congress mandated the fair inclusion of women in clinical research. And then where NIH guidelines for reporting analyses of sex and gender came about. And then finally, as recently as 2014, the NIH finally required the inclusion of sex difference research in preclinical sex. That just suddenly the Cornell network just went down. It's back. So what I was saying, what I was rudely interrupted, is that women's mental health is the evolution of that over the last 40 years has kind of been a subset of what's been going on with women's health generally, starting with the introduction of the first SSRIs, which really brought us into an era of expanded antidepressant prescribing, including during pregnancy and for menstrual cycle disorders. And then moving up into changes with the DSM, where premenstrual dysphoric disorder is now in the DSM. We're not quite there with postpartum depression. We have a definition in the DSM that isn't quite what those of us who do research in this area would think is scientifically accurate. And then we've also had national workshops on women's mental health. So we're getting there as part of a broad evolution. We have dedicated journals that are dedicated to either women's mental health or reproductive psychiatry. We have a huge number of professional societies that have now arisen, and some of these are purely geared at professionals. Some of them, like IAPMD, are geared at both professionals and the people suffering from these disorders. And we're starting to have public policy initiatives that are related to reproductive psychiatry. Most of these have been in the area of perinatal mental health disorders. For example, the 2016 U.S. Preventive Services Task Force recommendation that we screen for depression in all adults, including during pregnancy and postpartum, and more recently, the draft ruling by the same U.S. Preventive Services Task Force about anxiety. And we have specialized clinical programs now. There are reproductive psychiatry outpatient clinics, like the one that Dr. Hanso works in at Johns Hopkins. There are partial hospital programs, primarily for the perinatal group, and then there are inpatient units that are dedicated either to perinatal patients or to women more generally, and to disorders that particularly affect women. But we have a problem. Even though we have this expansion of research, even though we have this expansion of clinical programs, we have a real problem with the labor force. So if you look at who's treating people who have any kind of reproductive psychiatric complaint, including premenstrual mood syndromes, what you find is that there are a lot of psychiatrists in this country. There are a lot of obstetricians and gynecologists in this country. There are very few reproductive psychiatrists, so very few people who have that specialized training that's really required to understand these reproductive transitions. And that might not be so bad if general psychiatrists and obstetricians were actually being trained, and OBGYNs were actually being trained, but in fact, they're not. So a group of us decided to do something about this. It was back in 2013. I realize I'm wearing the same dress, so you can see that it's a hardy dress that's held up all these years. And this is the group that got together in 2013 to try to do something about the training of mental health professionals, and particularly of psychiatrists in reproductive psychiatry. We got together as part of a conference session. We were presenting a conference session about the state of education, and realized that we had such an impassioned response from the audience that we needed not just to document what the state of education was, but to try to do something about it. So the first thing we did was we wrote an opinion piece in the American Psychiatric Journal of American Psychiatry that was about the gap between the clinical need and education. So we've identified that there's a clinical need in people who suffer from reproductive psychiatric disorders, but we're not training either psychiatrists or obstetrician gynecologists in how to deal with this. And so we next went and identified, well, what are the minimum knowledge areas that we think a physician needs to understand in order to call him or herself an expert in reproductive psychiatry. And you can see here the minimum knowledge areas that we thought were important. And by we, I mean a group of academic reproductive psychiatrists who had specialized training beyond our residency programs. And you can see premenstrual mood disorders is one of these 6 key minimum knowledge areas. So then we decided to look at what are the actual requirements in residency training. So we all had a sense that this wasn't being taught, but is it actually required and not being taught, or is it not even required? And what we discovered was that as we expected, there is no requirement for psychiatrists in training to learn anything about reproductive psychiatry or hormonal transitions. There are requirements that you learn about child psychiatry, geriatric psychiatry, addiction psychiatry, forensics, emergency psychiatry, but not about reproductive hormonal transitions. In fact, one of my favorite facts that we discovered in doing this research was that in child psychiatry, the child psychiatry that you are required to learn as an adult psychiatrist training, it specifies that you have to have experiences with both male and female children, but the adult psychiatry requirements do not specify that. So no particular requirement to treat people going through female reproductive transitions. In addition, the requirements for training state that all didactic instruction should be coordinated with concurrent clinical experiences. And that brings up an issue that has been a big problem, I think, for getting reproductive psychiatry included in training, which is that some people don't have access to the special patient population. Some hospitals, for example, that don't have OBGYN services, people may not encounter patients who are presenting with these kinds of complaints. So we then did a couple of surveys of psychiatry residency training directors and reproductive psychiatry fellowship training directors to ask what is being taught. And the first one we asked is just how many hours of didactic teaching in reproductive psychiatry are required across 4 years of residency. And you have to think about this by remembering that the didactic instruction that is given to residents is about 5 hours a week for 4 years. And so we're asking over 4 years, how many hours are you teaching? And you can see that very few people are giving more than 10 hours of reproductive psychiatry training across the 4 years. A lot of people are giving none. And that's all of reproductive psychiatry. That includes the perinatal period, perimenopause, and premenstrual mood disorders. And so one of the questions we asked was, we wanted to know, is it not being taught because people don't think it's important? Or is there some other reason that reproductive psychiatry isn't included in residency training? And so we asked people to agree or disagree with a series of statements. And we found that actually the majority of training directors, so this was general psychiatry residency training directors, the majority of them do think we should be teaching it. They either think that all residents need to be competent in reproductive psychiatry, that's this red bar, or that maybe it's not quite as important as core disorders, but still it's something that we should be teaching. Very few of them think it's something we shouldn't be teaching, and yet we aren't. So why not? So the next thing we asked was, what are the barriers? And we came up with answers that we expected, but it was also really helpful for us to think about where to target our teaching. So one of the biggest reasons was no qualified faculty to teach courses. If we don't have any faculty in our institution that have knowledge of reproductive psychiatry, how can we teach that to the residents? And then the biggest reason was lack of time. So this is not a requirement. The ACGME, which governs residency training, does not require us to teach about reproductive psychiatry. They require a whole bunch of other things, and we just don't have time to fit this in. So after we got this information, we kind of took our show on the road and went to a whole bunch of conferences about women's mental health or conferences about psychiatry residency training to gather feedback. We held workshops at each of these conferences to get people's ideas about what kind of a resource would be helpful to increase the amount of training in reproductive psychiatry, given that nobody has time, given that there isn't local expertise in a lot of places. And what we learned was that many residency program directors really would love a resource. They do want to expand their training in reproductive psychiatry, but they just don't know how to do it at their institution. People told us that a web-based curriculum might be a feasible way to support a program's efforts, but nobody wanted to just put their residents in front of a computer and have them learn something. They want something that's interactive, that's engaging, that can be taught in a classroom, and that can support facilitator-led experiences in their own program. Nobody wanted to pay for this. Everybody said we don't have money for it. And we also found that people were interested in live in-person training opportunities for faculty members. The most important requirement, and this is reassuring, is that whatever we produced needed to be evidence-based. So what did we do? We decided to create this curriculum, and we modeled it on the ACGME core competencies, and we created core competencies for reproductive psychiatry. Once we had created those core competencies, we designed a web-based interactive curriculum. It's modeled on the National Neuroscience Curriculum Initiative, which is a similar web-based curriculum that residency programs can kind of pick and choose from for teaching neuroscience. And we created 13 different content areas as part of reproductive psychiatry that we thought were essential. And we then piloted the curriculum that we created in a bunch of different residency programs. Along the way, we partnered with MONA, which is Marseille of North America, which is the Perinatal Mental Health Research Society. And our project became part of the education committee of MONA. We did that simply because we needed a legal institutional entity, and it seemed more sensible to do that than create our own. We got this funding from the American Board of Psychiatry and Neurology, which was crucial for our ability to finish the website, finish creating the curriculum, and do that piloting that we needed to do. And we published some of that pilot data. So that's in a nutshell how we got to where we are now. What I'm going to do now is show you a little bit of the curriculum so you can see what it's like. We have a website. The website is ncrptraining.org. I'm going to have that on my last slide, so you don't need to remember it. I'll show you some screenshots of what the website looks like, and then I'm going to walk you through some of the materials that we use to teach. I mentioned before that it's a very interactive curriculum. So every subject that we teach has a guide that can be downloaded for a local facilitator to teach the subject. So we're trying to conquer that need for having local faculty who are experts in this area by creating a guide that does not require people to be an expert in the area to teach it. We give them all the answers. They just need to be a mental health professional, and then we can guide them through the answers and help them to teach the residents and trainees. So this is the homepage of our website. And we tried to get into here, everything about reproductive psychiatry. Our little calendar is our menstrual cycle, nod to the menstrual cycle. And once we get into the homepage of the website, we have 3 different types of materials that are housed on our website: classroom materials, self-study materials, and continuing medical education materials. And the purpose of having these 3 different types of materials is that, as I mentioned before, all the training directors who talked to us said, we really don't want something that we just put people in front of a computer. We want something interactive. So our primary mode of teaching initially was downloadable PDF guides that people can print out, take into a classroom, and teach from. But we also found a lot of people have used this material not in a classroom, have just used it to educate themselves. And so they can do that from those downloadable guides, but there are also self-study materials, which are either Word documents or PowerPoints or videos that give information that's in which somebody can learn on his or her own. And then continuing medical education. At the moment, we have 3 areas that you can take a test in and get CME credit for. We're evolving that into eventually having CME credit available for the whole curriculum. We just haven't gotten it all finished yet. And this is what it looks like once you log into the website. So in order to get access to the materials, you have to create an account and log in as either a facilitator or a trainee. And it's a really important part of the ethos of the NCRP that we want these materials to be freely available. We think that there's a lack of good standardized material in this field. And so we really want people to be able to access it. We don't want to make it something that's difficult to get to. But at the same time, we want people to be able to collect information on who's logging in. And we want there to be an honor system so that if people are teaching this within the context of a training program, we can have trainees log in as trainees and facilitators log in as facilitators. And I'm just showing you the sort of top bit of our website once you log in as a facilitator, and you can see that we have here 4 of our subject areas: the reproductive life cycle, which is really kind of menstrual cycle, pregnancy, perimenopause 101, talking about the physical changes that go on and giving a physical underlying for all of the psychiatric things that we then talk about in the rest of the curriculum. A module on premenstrual mood disorders, infertility and loss, and perimenopause. And then if we were to scroll down the page, we would see the rest of the 13 areas that we have information in. This is what a module looks like when you log into it. Every single module looks the same. It has our logo on it, and it has a paragraph about the topic that we're talking about and just sort of little caption about what that topic is. Then once you log in, you have a choice of using the facilitator guides for something that's meant to be an in-classroom experience, using a media module, which I'll show you briefly something about that, or using these self-study materials. So this is what our self-study materials look like. This is one that's designed specifically for PMDD, and you can see we give additional reading. We say who wrote this, and then we have an introduction and then specific targeted facts that we want people to learn and know, and specific questions, and then additional references at the end. As I said, some of these are Word documents, some of them are videos or other types of learning. This is an example of something from one of our media conferences. So every single module in the National Curriculum of Reproductive Psychiatry has a media conference. And we think this is one of the most important things that we do, because so often, those of us who are providers in this field, so often we will have questions from patients that have arisen from something that the patient has seen in the media. It could be social media, it could be traditional media, but examples will be reports in the media of scientific literature, some of which are accurate and some of which are not accurate, or things that get around on internet chat boards or other kinds of social media. And people often will come in with questions, and it's a really important job of the clinician to be able to understand what that media piece is portraying, to be able to discuss it with the patient in a way that is understandable by the patient, and discuss it in a way that makes a distinction between whether the media piece is accurate or not accurate, and whether the scientific literature upon which it's based is accurate or not accurate. So you can have a media piece that misrepresents what's happening in the scientific literature, or you can have a piece of scientific literature that itself has flaws and the media is accurately reporting that. And I think it's really important to be able to go through those things with our patients, and to be prepared to kind of translate that and interpret that as a way of making an alliance with patients about their treatment. And then we have the case conferences, which are kind of the core of our materials. This is an example of the facilitator's guide from our PMDD case conference. And what we do in each one of these is we give, as I said, advanced reading, we give an overview of the topic, and then it's a case conference. So we present a case, we talk specifically about things that have to do with that case, and it's usually done in a progressive manner so that we're presenting a piece of the case. We stop and we ask questions. We ask people to say, what's the differential diagnosis at this point? What are the symptoms that are leading you in one direction or in another direction? And then we'll present the next part of the case. And we usually find that we have additional things revealed in the next part of the case that we didn't have revealed earlier, to lead people toward one or another conclusion about the differential diagnosis. So I'm going to show you a little bit of that facilitator case conference for our premenstrual mood disorders module. I'll just briefly present the case to you, and then I'm going to show you a few video clips that will show you how we walk through these different progressive parts of the case. So the case that we use in our premenstrual mood disorders module is a young woman named Felicity. She's 26 years old. She's never been pregnant. She's a single woman, and she works as an event planner. And her chief complaint when she comes to see the physician is, there's something wrong with my hormones. Her past medical history doesn't have a lot of medical problems. She's a bit overweight. She has mild asthma. She doesn't have any prior psychiatric history. She does note that she has a sister who has fibroids and really heavy periods. And she herself first got her period at the age of 12. And she had, by the time she was 14, she had heavy and prolonged bleeding with a lot of pain and some mood changes that accompanied her period. And her mom took her to see a gynecologist. She started on oral contraceptive pills, which she took for 12 years and didn't really have any of this prolonged bleeding, no more issues with pain and mood changes during the whole time that she was taking the oral contraceptive pill. But she recently stopped because one of her sisters had been diagnosed with a blood clotting disorder, and her doctor told her that it might not be such a good idea to take an oral contraceptive when she had this family history of a blood clotting disorder. So she's coming to see you now because she's been experiencing some severe pain, bloating, cramping, heavy bleeding, and also some mood changes associated with her period ever since she stopped taking the oral contraceptive pill. So I'm going to actually stop sharing my slides so that I can bring up the videos that I'd like to show you. And what these videos are going to show you is we have 3 separate videos, and it's 3 different possible presentations of the same patient. In the first video, I'm going to start it in the middle because the patient has already given us some information about her bleeding. She's told us that she has heavy bleeding, but not outrageously heavy. She's soaked about 4 pads a day. She tells us that she's got a lot of bloating and a lot of cramping. The cramping is pretty severe, and it causes her to miss work at least once a month because of those physical symptoms, lots of breast tenderness. And I'm going to start the video at the point where she starts talking about mood changes. So just give me a sec to share the screen. And somebody jump in and let me know if the sound works, because we were messing with that just to make sure I got the right one. Okay.
You mentioned something about mood changes too. What do you mean by that? So I just feel so much more sensitive. I cry more easily in the week before my period, and I worry about whether or not people like me. Sometimes I get really pissed off when people do stupid things, much more of a hair trigger than usual.
Do you miss work because of these mood changes, or get into fights with people or into trouble at work?
Nothing like that. I notice a change, but I'm not sure anyone else does. I try really hard to make up for it. I've never missed work or gotten into a fight, so nothing like that.
That's good to hear. What happens when your period starts? Do these symptoms go away?
So that's the amazing thing. For the most part, they do. I still have the cramps, but all the other stuff just fades away by about day 2.
So what we do with that video is we're presenting a case where the patient talks about mood symptoms, but they're clearly confined.
It sounds as though
Clearly confined to that premenstrual period. They're not debilitating. They're not really affecting her functioning. And so after we go through that part of the video, we ask the trainees to think about that, to talk about that. And we end up concluding that this patient who's presenting has likely got PMS because she's having some symptoms, both physical and mood change symptoms, but they're not debilitating. What we do next is we then show the next part of the video, which is same patient, but it's a little bit different story. Like it's a what if this patient were presenting a little differently?
miserable. You mentioned something about mood changes too. What do you mean about that?
So that's the part that really bugs me. I almost feel like I'm a completely different person in the week before my period. I cry at the drop of a hat. I feel so low and like I'm not worth anything. At the same time, I feel keyed up, like I can't concentrate and I can't sleep. I eat so much junk food and I just feel like things are spinning out of control. And sometimes I really lash out at other people. I got in a huge fight with my boyfriend last month, and the month before I was so argumentative with my boss, but fortunately she knows me really well and she knew this wasn't like me. So she just told me to take a walk to cool down. Thank God, because if I had kept going, I probably would have been fired.
So sometimes when people feel that low, they can even think that life isn't worth living or think about wanting to harm themselves. Did that ever happen to you?
So I don't really like to talk about it, but last month it did get so bad that I felt like I just couldn't stand myself. I thought about all those bottles of ibuprofen, and I pretty seriously thought about taking all of them.
That sounds really scary. How close did you come to actually taking those pills?
So the first time it happened, I just thought about it and I was so horrified that I went out for a walk so I wouldn't be in the apartment with the pills. But the next day when I got home from work, it was all I could think about. So I went to the bathroom and got the pill bottles out and carried them around the house, but I didn't open them. I was really scared.
I'm really glad you came in. That really does sound frightening. I think I have a good idea now of how bad your symptoms get just before your period, but I still have a few more questions. What happens when you get your period?
So when I get my period, the first day it's not really any different, but by the second day I'm feeling like myself again. It's like a light switch goes off, and then I'm completely fine until 3 weeks later I get snapped again.
And so this second part of the video is obviously meant to show that we're having a different presentation. These are symptoms that are debilitating, that are serious, and that are more consistent with a picture of PMDD. But we then teach the trainees, we can't diagnose it with PMDD because we don't have prospective tracking of her symptoms. So the third video that we show trainees is when the patient comes back after having done prospective tracking of her symptoms.
For coming back to see me. I'm glad that you were able to keep track of your mood. Tracking mood prospectively is the best way to diagnose PMDD. Let me have a look at those mood trackers. So remember that day 1 is the first day of your menses, and I can see that you have a regular 28-day cycle. Do you see a pattern here? Is this what you were expecting?
Yeah, for the most part. I can see that things are much worse the week before my period. So like I have a lot of 5s and 6s here.
That's right. Things are a lot worse in the week before your period. And that's what I expected to hear from you last time. But I'm really interested in some of these numbers here. Do you see how you have a bunch of 3s and 4s here and around the middle of the month, and some ones scattered around here as well? What do you make of that?
Well, I guess I wasn't really aware of that. It feels so terrible in the week before my period that I guess I didn't even notice these other days. But you're right, they are scattered all over the place. What does that mean?
Well, it's very common for women to have some kinds of symptoms before their periods, but to qualify for PMDD, the symptoms really have to be absent in the rest of the month. So that doesn't seem to be the case with you. So I think you actually have what I like to call PME, or premenstrual exacerbation of an underlying mood disorder. So there is no official diagnosis with these initials, mind you, but it means that I think you have a mood disorder that is there all the time, and it gets a whole lot worse in the premenstrual period.
So does it really matter whether we call it PMDD or something else?
Well, yes, actually, it might. We have different approaches to treatment for PMDD and for other mood disorders, such as major depressive disorder. So have you ever had a time in the past when you were feeling low all the time for at least 2 weeks?
Yeah, I think I have had something like that. Maybe when I was in college, like around the spring of my sophomore year. Just couldn't really get out of bed, and I did really terribly in school, but I thought it was just stress.
It's often hard to say looking back that far, but that might be an indication that you are more prone to depression more generally.
Well, is there something I can do to feel better?
Hi, my name is Olivia Lance from IBM Quantum. I'm here today to
So you can see by the use of those 3 videos that it's a progressive way that we're trying to teach clinicians the difference between PMS, or difference among PMS, PMDD, and PME. And the videos are, showing you a sort of, picture perfect patient who has exactly the right kind of symptoms that will allow you to make that diagnosis. But for our trainees, it's really the first, for many of them, it's the first encounter that they've ever had with a patient who's presenting with these kinds of symptoms. And they often haven't thought to ask these questions before. I'm going to go back to my slides now. Just give me a sec to get there. So. Okay, so that's, as I said, an example of how we go through one of these modules in the National Curriculum in Reproductive Psychiatry. Every content area that we have has a module like that has videos and a case presentation and walks people through a differential diagnosis. I mentioned at the beginning that we started out with this curriculum really geared at psychiatry trainees. And the reason for that was that we were all psychiatrists, and that's where we noticed the gap. And so the first part of what we did was to gather information about piloting this material specifically in psychiatry residency programs. We had all of our modules peer reviewed. So we had a group of academic psychiatrists creating these modules, and then we sent them out for external review from other reproductive psychiatrists. And we did this in 2 groups, and that was simply pragmatic. It took us time to create all the material. And so we had one group that was ready the first year and another group that was ready the second year. And we managed to get baseline demographics, attitudes, and knowledge collected from about 282 residents who piloted these programs. I'm sorry to say that the number who completed our post-test was much smaller than the number who completed that baseline survey, but we do have some data that we were able to collect about whether this curriculum works. Does it work either to change attitudes or does it work to improve people's knowledge? And so the first bit of information that we collected was we just asked programs that piloted the material, did you actually do it all? Did you complete all the modules? And we had a maximum of 10 modules in this piloting program. And you can see that most people did not complete 10 modules. The highest number that people completed was around 6. And I'd like to show that data to remind people when I show you the knowledge test that people's knowledge did improve, even though we gave them a knowledge test based on all of the modules. And in fact, they didn't complete all the modules. So the improvement in knowledge would probably have been higher if they had completed all the modules. The first thing we asked was about their feelings of preparedness. So after you've completed this curriculum, do you feel more prepared to treat people with reproductive psychiatric complaints? And you can see here we have the light gray bars are before they did the curriculum, and the black bars are for after they did the curriculum. And you can see that beforehand, nobody felt well prepared to treat people with reproductive psychiatric complaints, but that afterward, everybody felt either somewhat or well prepared, and nobody felt unprepared. And these 2 different graphs are just with the people who completed that first group of modules and the people who completed all the modules in the second year. And then we looked at a content test. So we gave a test, I think it was 29 questions spread out across all of the content areas that we teach in the national curriculum. And we compared the score on that content test from before doing the curriculum to after doing the curriculum. And you can see that there was a statistically significant increase in that score. This is for the people who did the modules the first year, and this is for the people who did them the second year when they had the larger group of modules. And so you can see it's a statistically significant and we hope meaningful jump in people's score. So where are we now with this project? I've mentioned a couple of times we started out with this focus on psychiatry trainees, but we've really expanded from there in a couple of important ways. A couple of weeks ago, we had our first ever in-person CME event based on the NCRP, where we taught, the highlights of the whole curriculum over a 3-day span as an in-person CME event. And we're going to try to be doing that on an annual basis from now on. We also have a partnership now with ACOG, the American College of Obstetricians and Gynecologists, to adapt these materials for OB and OB-GYN trainees. What we found when we started talking to OB-GYNs about this was that our materials, which were these, lovely, long, discursive PDFs that you could print out and share in your discussions with your trainees, that's not really suited to the OB-GYN trainee world. They are very busy, they move very fast, they are surgeons, and they need something that's more bullet points, that's much cleaner and faster, and they need less information than a psychiatry trainee might need. So we're adapting all of these materials into a format that will be specifically for OB-GYN trainees. It's going to include some podcasts and more PowerPoints and things of that sort. And then we also started a program called the NCRP Trainee Fellowship. One of the problems we faced when we first got finished with all the material was, okay, we did all this work, we created all this material. How are we going to make sure that we're keeping it up to date? And how do we make sure that we're adding in things that are new that we really need to keep abreast of? And so we started a trainee fellowship, which is a competitive program that people can apply to. We add one new fellow every year. It's a 2-year program. And these are residents and fellows who are still in their training, who can bring to us that point of view of people who are in their training and can help us to keep these up to date. We currently have 2 fellows, Juan Pablo Aparicio and Tololope Odobunmi, who are our current fellows, and we had 2 wonderful fellows who have now completed the program. And then the final thing that we've done is we started a virtual didactics program for people who are in fellowship, so not residents, but people who are fellows in either women's mental health or consult liaison psychiatry. This is a virtual program. They meet on Zoom. We have 2 sessions a week. Last year, I think we had about 25 fellows enrolled across the country. This year, we have a slightly higher number, and we're collecting data on that program. And so far, it seems to be both popular and it seems to be improving their content knowledge of these areas. So I'm going to stop there and let's have a conversation. Let's hear your questions, and I'm happy to answer any of them.
Thank you so much, Dr. Osborne. That was really interesting. Let's see. I don't have any questions in the Q&A yet, so if people have questions, feel free to put them in the Q&A. I had one sort of thought, and I was going to ask about this, and then you hit on it at the end, so I was really happy to hear. I know that the main focus has been on psychiatry residents. In 2018, IAPMD did this global survey of people who had been seeking care for PMDD treatment, and they were asking about that experience with their care providers. And the patients reported that psychiatrists and gynecologists were actually the best in their perception of sort of awareness of PMDD, knowledge about PMDD, which is awesome. And then they rated psychologists as being really great at that sort of interpersonal stuff. And then they rated gynecologists as the most likely to ask them to do the daily tracking. So I thought, and primary care doctors were rated like not so great in like most of those categories. But my comment was that I'm really glad to hear that you're kind of expanding it from psychiatry residents and getting it to OB-GYNs as well. Yeah.
And I think, primary care doctors is another audience that it would be great to get to. Absolutely.
Family medicine. Yeah. I think there's a lot of people who start there.
We did, one of the programs that piloted our original series of materials was a group of family medicine residents. And it was really interesting to see their reactions to it, because they also had a big improvement in knowledge as a result of doing the curriculum. They were less knowledgeable to begin with, right? So their ending score was about the same as the beginning score for the psychiatry trainees, but which just makes sense, right? They're not mental health professionals, but clearly, even though it may not have been adapted specifically for them, it did help them. And so that was encouraging to us as another audience that we could go for.
I have a kind of a broader sort of field question for you, like that I think was raised, this training is so amazing, so necessary. I think for me, I really, lately, my grants, I really studied PME, PME of depression, PME of suicide. And I have to say, in terms of the symptom patterns, the trajectory, I don't think it's a different thing than PMDD. I think that there are subtypes, right? Where there's probably different kinds of hormone sensitivities, and maybe some are more common than others. And maybe there are some that tend to overlap with MDD more than PMDD alone, right? This kind of thing. I'm sure there's a lot of diversity there to explore. And I'll say mea culpa, I've been somebody who's written about the difference between PMDD and PME, and how maybe we do need to think about that distinction. But the more I see my own data, the more I talk to people, I'm seeing, I study patients with chronic suicidality, and so many of them have severe luteal phase changes and irritability. And so I'm just wondering about, I'm kind of to the point where I'm we just need to take away this criterion that requires full clearance. I don't understand why, if they're changing just as much on a symptom, we wouldn't treat that like PMDD. So obviously there's not a lot of data, but I guess I just wanted to get your reaction to that and see what you think about it.
Yeah, I think it's an interesting idea. I think we need tons and tons more research. I think PME is vastly under-researched. And as we said in the video, there isn't an official diagnosis of PMDD, PME, even though there is one of PMDD, and at least not in the DSM, but in other places, there's an official PMS diagnosis. But I think the reason that I've never been comfortable lumping them together, I think it's two reasons. One is the data that shows that OCPs can be helpful to people with PMDD, but not people with PME. And maybe those data are changing, or maybe that we don't have enough data there.
There's one trial, right?
But that's been part of my reasoning, so that why wouldn't OCPs also help in PME? Maybe we just need more research there to know whether that's true. But the other reason that I, as a clinician, like to make the distinction is that I would say I get a lot of patients who come for an evaluation for PMDD. These patients they think they have PMDD. Some of them do have PMDD. Many of them do not. Many of them have PME, and they don't want to have PME. I think that there is our country has a huge stigma about mental illness. And if people are told they have depression with a premenstrual exacerbation, that is much less acceptable than saying PMDD, because I think people think of PMDD as, it's hormonal, it's not a mental illness. The reality is they're both mental illnesses, right? And it doesn't, and they both have a hormonal component. To my mind, there isn't a distinction that way, but I think it's very difficult in terms of the stigma of our society. And so making that distinction, I think it's just difficult having that conversation. And I think people who do have PMDD often really want it to be separated out from PME.
Of course. But I also see, in my data that most people with PMDD have a comorbidity, right? So it's at that point, how do we use the daily ratings to really distinguish? We can, but we're really reaching and getting pretty subjective there, right? About what the distinction is. So, this is really helpful. I think, making sure that we work on this mental health stigma thing in the PMDD community is so important, because there's so many people with PMDD where the PMDD, I think, does create the chronic disorder, when you're constantly sort of undermining your relationships or losing jobs or whatever it is, developing a depressive disorder on top of that has to be sort of what we would expect, right? In many cases. So I think normalizing the idea of treating that as well seems really important. And of course, sometimes, you give the SSRI for one and it's helping the luteal phase irritability anyway, so it becomes sort of a non-issue. But I do think as some of these other hormonal options become more accessible to people with PMDD, the question of gatekeeping folks with just sort of a higher intercept, but no differences in cyclicity, becomes a really interesting question that I'm really kind of.
Yeah, and I think, the other reason to really think about it and to make sure we can do the research that figures out these distinctions is that a lot of people don't realize this, but oral contraceptives are higher risk drugs than antidepressants, right? They're associated with stroke. If you're a smoker over 35, you shouldn't be taking them, right? And so they're a much higher risk drug, and yet they're more acceptable to people because they're not a mental health drug. And so I think figuring out for whom the hormonal treatments work is really, really important, right? Because we don't want to be giving hormones unnecessarily to people to whom they won't help. And we want to decrease that stigma for giving antidepressants, which really do help a broad group of people and which are lower risk drugs. And right now, I just don't think we have enough research to be able to say definitively who are those people who the hormones are going to help and who are the people who the hormones won't help.
Yeah, and this is like kind of the focus of my clinical trials lab, which like they're hopefully finally going to be coming out this year, but it's really helpful to hear your perspective on this. Thank you so much.
Sure.
Let's see. So I've had a couple questions come in. Let's see. There's one in the Q&A, which Tori touched on a little bit. Are there thoughts that some psychiatric disorders, e.g. eating disorders, OCD addiction, might be maladaptive coping mechanisms developed from PMDD? And so Dr. Eisler-Mel had kind of touched on that, it might make sense that, you might start off with PMDD and then, end up having other symptoms kind of almost in response to it. So I think that's a reasonable question. Let's see, for Dr. Osborne, there was one question. Let's see, where did this one go? Let's see. So is there a way to get connected with the NCRP? So this person says, I'm a clinical psychologist. I also live with PMDD. Would love to help facilitate some training in the psychology or therapy domain.
Yeah, absolutely. And one of the things that I tend to not have time to explain, but should always explain is that I talk a lot when I present about the curriculum about psychiatrists and about prescribing, simply because that's the audience for whom it was originally made. There is psychotherapy incorporated into everything, but we always are happy to have more people helping us with that aspect of things. And I'm going to put into, if I can just move my windows enough, I'm going to put the our email address for the reproductive psychiatry for the NCRP into the chat so that you guys can email us if you're interested in getting involved. We are always happy to have help. Let's see. And I'll put my email and our website all into the chat. Okay.
And let's see, there was one other question that had come in that was asking about whether patients were consulted on any of the NCRP educational materials, which I thought was an interesting question.
Yeah, that is a great question. We did have the people who you saw in the video are not patients. They were actors. One of them was actually, they were both research assistants, but so we did not use patients as actors in any of our videos. But we did consult with patients on the creation of some of the materials, particularly the case presentations. We do not have none of our cases are identifiable as particular patients, but we consulted with patients about the feelings that they were presenting in those cases. So yes.
That's really good. Awesome. Let's see. Any other questions for Dr. Osborne?
Do you get any pushback on the daily ratings? People being worried about how to interpret them. People because some of the work that I've done is like people interpret them very differently than one another, and it's kind of like people are like, this is subjective. What do I do with it? Do you hear that from trainees?
I hear that, and I'll tell you. You mean from the trainees rather than from the patients?
Yeah.
I definitely get pushback on that from the trainees. I also will say it's really hard to do those 2 months of prospective ratings, and the number of patients who are not able to complete that is very, very large. So I will do it in a very flexible manner. So I always start out with the DRSP, and I ask them to do that. If that's something that that is not compatible with that patient's life, we'll go to something else. I'll say, we'll do a simpler mood tracker. I'll say a smiley face or a frowny face. Some people do period trackers, and I ask them to keep track of it that way. But I'm pretty flexible in my approach to it because I want that prospective data, but I recognize the DRSP is really, really hard to do. And then, yes, I absolutely get it from trainees saying it's too subjective, or, different people mean different things by it. But the way I respond to it is, yes, for one person, a 6 might be a 3 for another person. But so the numbers themselves aren't that important, but you can see as pattern nevertheless, right? If somebody is having symptoms during the middle of the month, that's a pattern that looks different from somebody who has symptoms only at the end of the month. So the actual severity, marker of severity, I don't think is very accurate because different people have different perceptions of that. But whether there are symptoms in the middle of the month versus only at the end of the month, I think is less subjective.
All right, well, we have another 2 minutes or so. So if anyone else has any other questions, comments, before we start to wrap things up.
Yeah, I see a few things in the chat about people saying, people feeling fobbed off by providers, right? And I think that that's a really important point. And I think it's one of the reasons that we really wanted to do this training is I think that that's a really common experience it's a common experience for women generally. It's especially a common experience for people with premenstrual mood disorders and perimenopausal. Both of those are areas where general psychiatrists, general gynecologists, general primary care doctors dismiss the symptoms or don't even ask the right questions to know if you're getting at the right symptoms. And I think that can make patients really feel unheard and unlistened to. And I think that that's a really important point. And the reason that we wanted to do this training is, I'm glad that I'm a reproductive psychiatrist and that I had that specialized training. And this is the population that I want to work with. But most people never get to me, right? Most people go to a more general doctor, and they're not in an area where there happens to be an academic center with specialized reproductive psychiatry. And it's those more general clinicians who really need to have an understanding this, so that when they hear somebody talking, they know to just ask the right questions and they know to not dismiss it. And I think that that's, there are never going to be enough reproductive psychiatrists for all of the people who experience reproductive psychiatric issues. So we have to train that more general workforce to at least recognize it, ask the questions, and then if necessary, get the person to a specialist.
Yeah, I think therapists, likely should would be often therapists have specialized training in assessment too, right? So really would be a good way to increase the net, I think.
Absolutely.
I think the SSRI question, people, in my experience, patients don't mind being prescribed SSRIs as long as you really explain that they're evidence-based for PMDD and maybe even work a different way, right? I think
it's so common within the PMDD community in the groups for people to come away thinking, I'm not depressed. Why did they give me this? They didn't listen to what I was saying. Yeah. That's what we see over and over and over, rather than spending perhaps 2 minutes just explaining, it is very researched for PMDD and this is how it could work, and perhaps it could even work quicker. I think it's really important to reflect that.
Yeah, I think that's really important to explain what the evidence is supporting them, that no, this is not major depressive disorder, but this medication also works for PMDD, and here's how and why. And also I think it's important to discuss the literature about the risk for OCPs. Not that we want to scare people away from taking OCPs, but that just because a disorder is based in a vulnerability to hormonal fluctuation does not mean that a hormone is the right treatment for it. And that's the way I explain it to patients, right? Yes, it is your vulnerability to hormonal fluctuation that has gotten you there, but that doesn't mean that the way to treat what you have is by giving you a hormone. It might be, but it might not be.
All right. Well, I think we are just about out of time still. I want to thank Dr. Osborne again for this really interesting presentation. And yeah, thank you everyone for attending.